Thank you. Well, basically, as Dr. Dhar had indicated earlier, this is a very unusual kind of panel discussion where the audience is composed not of dermatologists but of pediatricians. So our first I should call on the stage the panelists, Dr. Sahana P. Raju, the youngest one, I suppose, from Bangalore, Dr. Sandipan Dhar, the senior most. No, not the senior most. Yeah. And Dr. Sahana Srihari from Bhatinda. Dr. Sujata Sengupta will not be there. Dr. Safia Bashir. Thank you. And finally, last but not the least, Dr. Arijit Coondoo, the senior most. Okay. So here we'll go. Basically, as I also believe that from this unique audience, we, the dermatologists, have many things hopefully to learn. I would go frequently to the audience to have their take, but any of the panel discussions, panelists, as well as any member from the audience will be free to interject at any point they like. This is an entirely case-based discussion. We'll have about 6 cases, but if we run out of time, just remind, we'll be closing shop then. Well, this is the first case. There is just a very subtle erythematous maculopapular rash on the upper limb. And if you look at the hard palate, there are some purpuric spots. So this was the presentation. Subtle erythematous macules on ventral forearms, bilateral symmetrical, slightly itchy, petechiae on hard palate, bilateral cervical lymphadenopathy, high-grade fever, but it has come down to a low-grade fever for the last 2 to 3 days at the time of presentation. History of lamotrigine, which was started 6 to 7 weeks ago at the dose of 25 mg and doubled. The dose was doubled 3 weeks back. The drug was last taken the day before the onset of the manifestation. No sore throat, no facial edema. Now, with this, I will go to Dr. Sandipan Dhar. What are the differentials? What will be your differentials at this point?
Sorry, the age of the child?
Yeah, the age of the child is 14 years.
14 years?
Yeah.
Right. Looking at the presentations and, histories, I would like to consider a few possibilities in this particular case. My first possibility will be, you have not mentioned about, hepatosplenomegaly or anything. It was not.
Those were not there.
Those were not. Okay.
Yeah. Only the positive findings, other than 2 very important negative findings were given.
Okay. Perfect. So, I would consider EB virus infection, Epstein-Barr virus infection as one of the conditions for this.
Okay.
The other will be, parvovirus B19 infection.
Okay.
Right. And third is, you said bilateral lymphadenopathy.
Yeah.
Cervical lymphadenopathy.
Cervical lymphadenopathy.
Bilateral cervical lymphadenopathy.
Yeah.
Right. And petechiae in the hard palate. I think there are certain clues from these petechiae on the hard palate bilateral cervical lymphadenopathy and the type of rash which you have described.
Right.
We cannot go away from a diagnosis of a rickettsial disease here.
Okay.
That also should be one of the differential diagnoses. And my fourth and last possibility will be a dengue fever.
Okay. So you will be discounting the possibility of any lamotrigine-induced drug reaction.
I don't think seriously.
Okay. Okay. Anybody else from the panel?
Sir, I would rule out drug-induced rash because the drug was started 6 to 7 weeks ago and there's no facial edema. That
Yeah.
would be against a drug rash. I would also consider Kawasaki because of cervical lymphadenopathy and oral
Okay.
lesions. Also think of an autoimmune condition because it's an
Like?
elderly child, like SLE maybe, because of the heart, palate, ulcer and fever.
No joint pains, nothing.
Yeah.
Okay. Yeah. Fair enough. Anybody else from the audience or then, okay, from, sorry? Rest syndrome. Rest syndrome due to lamotrigine. Very good.
One more.
Very good. Yeah.
Somo. You are saying that the lamotrigine was started 6 to 7 weeks ago,
Right.
and the fever appeared when? Before lamotrigine or after?
No, no. The lamotrigine is being continued. So
Or the fever?
yeah.
we-
The drug was last taken the day before the onset of the signs and symptoms. That means the fever.
But still we cannot discount the drug reaction.
Yeah, that's what he said. His suggestion is dress. So your suggestion among the drug rashes, what kind of drug rash? Dress or any other? Sorry? No hepatosplenomegaly. No. She is the daughter of a doctor.
And there was no eosinophilia.
Sorry?
There was no eosinophilia. Eosinophilia.
I'm coming to the investigations later on, right?
Because without
Right.
that we cannot discount dress.
Yeah, fine. So you are also going in favor of dress if it's a drug reaction, right? So any other possibility from anybody in the audience? Otherwise, we'll go forward. So what kind of investigations will you do? Dr. Srihari?
Initially, the routine blood investigations, the complete blood count,
Okay.
to see the cell count, and any organomegaly to be looked for.
Okay. No, I'm talking of investigations. Clinically there was no organomegaly.
Yes.
So
The complete blood count.
complete blood count.
And the liver function tests and the renal function tests. To see if there's any systemic involvement.
Anything you do to rule out infection, as Dr. Dhar was very, lateralized towards the infection. So anything you do for ruling out infection? In fact, the first differential he told was EBV, very specific for infectious mononucleosis. So anything, it has got certain resemblance to that, don't you think? Okay, so anybody from the audience, any specific investigation that you would like to do at this point? Peripheral smear that she has already told. Anything else? Eosinophil count, that will come from the peripheral smear. Then? Sorry? Can you just speak on the microphone, please? It's not audible.
Sir, VCA, viral capsid antigen for infectious mononucleosis.
Okay, fine. Okay,
Paul Burnell test and VCA both, in fact.
great. Well, so the patient was admitted. As I told, she was a doctor's daughter. They did not take any chance. BioFire tested positive for influenza B. Now, but we all know that influenza BioFire can be false positive. Monospot was negative, infectious mononucleosis, Paul Burnell. COVID screen negative, RPR negative, because somebody thought that it could be syphilis also. WBC slightly diminished, but there was no, absolute neutrophil count was 1100, no lymphopenia, nothing. ANA negative, LFT, renal function tests, thyroid function tests, all within normal limits, nothing. So, any changes in the DD at this point, Dr. Dhar?
Well, you have not mentioned about the peripheral blood smear, you said normal.
Yeah.
No eosinophilia.
No eosinophilia.
Okay.
No eosinophilia, no lymphopenia.
No lymphopenia. I was thinking initially also one of the type of influenza actually.
Okay.
I kept my differential mostly among the viral infections. If you have noticed it carefully, all the possibilities was indicating towards a viral infection, because hemorrhage in the palate is something which was very striking.
Right.
Right, which does not occur in most of the other conditions.
Can it? Yeah. Now, other than race, can it be an evolving SJS? Why I tell you, because this is one of the chocolate questions. Sorry, I was not informed about this chocolate thing before. So the questions are absolutely impromptu as they appear in my mind. So anybody from the pediatrician, any idea about how many % of SJS can be accompanied with fever? To the panelists also, anybody answers it, gets a chocolate. Sorry? Almost? Not 100, but okay, because you were in that zone, you will get a chocolate. 85%, and this is from a systematic review. Okay, so so other than influenza, and as far as the biofire is concerned, let me tell you that around 10% is the false positivity rate.
Positive, true.
And do you think that this kind of rashes and this kind of cervical lymphadenopathy, they would be extremely rare in influenza. I'm not saying that they cannot occur, but this will be extremely rare.
Right. Agreed.
So any change in the DD? Anybody? Platelet count was normal. Only some leukopenia. 2000. That's also nothing, Sorry? Yeah. So, let me tell you the further course. She was discharged a day later, afebrile and with persistent but improved leukopenia and neutropenia. Some temporary worsening of rash with urticarial-like lesions, but these two improved. She never developed mucous membrane involvement or lesions typical of DRESS or SJS. Other than that, her palate petechi, there was nothing. Not treated with anything other than antihistamines. Final update, patient recovered, WBC normalized, rash was never severe, didn't meet the criteria for DRESS or SJS. So probably been due to lamotrigine, but not meeting criteria for DRESS or SJS. There is hardly any viral fever which will go out in just one day. Very, very rare. Mild drug rash. Resolution did not occur in one day.
Please use the microphone.
Resolution did not happen in one day. The fever reduced in one day. As I said, the resolution of the rash took a few days.
You see, the pointers here are that you have a person who's been on drugs since about 7 to 8 weeks.
6 to 7 weeks, yeah.
6 to 7 weeks, developing fever after about 7 weeks, not unknown, but you are saying that the fever responded within 1 or 2 days without giving anything at all.
Yeah, That's what happened.
That is not consistent with a drug reaction because you see.
But is it consistent with any kind of viral infection that you can think
Yes,
of?
it is. It is. You have cervical adenopathy.
Yeah,
You have cervical adenopathy. Patient develops fever.
right.
So he develops he develops some kind of a viral infection. It's difficult from these investigations.
What kind of, that won't be
Yeah, some
basically
kind- yeah, some
come
kind.
out positive with biofire?
Yeah, so, yeah, it could be. It could be. Even it could be. It could be influenza B. It could be influenza B. Because see, the drug has been on for such a long time. Develops 1 day fever and resolves.
Yeah, just after the withdrawal of the drug.
See, that is what I'm. So the thing is, when a rash occurs with a drug after 7 to 8 weeks, it will not resolve in 1 day of withdrawal of the drug. That it will not resolve.
I do not think you can.
So
I mean, there
and
is
he's
such
got
a role. I mean,
an adenopathy.
this is-
He's got a bilateral cervical adenopathy.
Right.
Okay, it's very unusual. Very unusual.
Very unusual. That's why this case is being presented here.
So I agree with Manoj. Sorry, Somo. I agree with Manoj. I still persist with the diagnosis of EB virus infections. Why? One of the reason is definitely fever. Second is bilateral adenopathy. Third is hemorrhagic lesions in the palate.
But with a negative monospot.
Huh?
With a negative monospot.
That you have to go and you must have gone to the literature and seen what percentage of EB viral infection it may be negative.
Yeah, it might be. It might be. But my point is a very old apothegm. Any drug can do anything, including death. I mean, in the absence of any clear-cut hard evidence in favor of a viral infection, I would rather be of the hunch that it was caused by lamotrigine. Anyway, thank you all.
Yes,
Yeah,
I don't want chocolate, but
you already had yours, I guess.
I still feel, see, what comes to my mind, anything which comes and goes suddenly is more in favor of virus. With leukopenia is our favor in, see, we are not contrary, but these things are in favor of virus. Drugs will not go suddenly. Within a day, only virus can disappear, not other things. So that is what is our contention. Now, you may be correct, but this is what I thought
But,
I must share with you.
You know, what is the half-life of lamotrigine?
So was the drug
Yeah.
stopped in this patient?
Sorry?
Was
Yeah,
the drug
the drug
stopped?
was stopped.
But that was not an indication to-
Basically, after 2 days of stoppage of the drug, the patient became afebrate.
Sir, also Epstein-Barr virus will not come positive in biofire. For that we need to do its
for
particular.
for that monospot was done. Biofire was
Sir, a
not.
single monospot negative is this hard palate petition is very characteristic of Epstein-Barr virus reaction. So cervical lymphadenopathy, how do you explain that with drug withdrawal or drug reaction? Very, very uncommon. It's not matching the picture at all. More likely to be Epstein-Barr virus. Even
So
with
you
a
see-
negative
So you see, the
monospot test.
half-life of lamotrigine is about 24 to 35 hours.
Yeah.
Now multiply that by 4.
Yeah.
So that means it's about 6 to 7 days.
Not
Here-
6 to 7 days, around 4 days, 4 to 5 days. So
So the thing is, I don't know. It's very. I mean, I don't know.
it is not an open and shut case. That's why this was presented in the panel discussion. So the point is, in many of these cases, we might not have any kind of fixed diagnosis with hard evidence coming up. That is the basic learning point here. Now, let's come to the case number 2. Well, it's the 12-year-old boy with this kind of disformation of the upper lip and hyperpigmentation in the lower lip, and there is a perioral xerosis with some kind of thin scaling near the angle of the mouth. So this was the presentation, 5 to 6 months history. The boy was vegetarian, his whole family was. No medications, no other areas of involvement, no pigment alteration elsewhere on her skin or nails, no internal oral mucosa pigmentation. What are the differentials, Dr. Srihari?
So first we could consider vitamin B12 deficiency.
Vitamin B12, okay.
And vitamin B complex deficiencies generally don't occur individually. It's always a combination. So B2 and B6 deficiency could co-occur in this patient. But
Either B2, B6 or B12 or all acting together.
yes.
Okay. Any other? I mean, what do you make of the xerosis and the scaling? I mean, one of the, in fact, the first clinical presentation or alternate presentation of riboflavin deficiency that you presented in your lecture was a seborrheic dermatitis like a presentation, right?
Yes.
So, other than nutritional deficiency, can it be any other thing? No history of any medications.
Can it be like a lip lick or scalitis or
Sorry?
habitual licking of the lips?
Habitual lipping of the lips. Licking of the lips. So, yeah, that's an interesting proposition. Okay. And any other thing?
Any drug history, sir?
Sorry?
Any drug history?
No drug, as I said. Sorry? No medications.
Social media directed apple vinegar oil, tonics, vitamins, supplements, serums, they keep on taking. That's why I wanted to ask.
No, basically they did not give any history. Sorry? Want to see this? Okay, fine. From the dermatologists, I mean, any possibility of Logier-Hunziker syndrome?
You have said that, I was thinking of two possibilities, in fact.
Right.
One was definitely Logier-Hunziker syndrome. But there you see multiple, melanonicia strata. While you have said very here categorically, there was no other area of the, skin and
I mean,
mucous
still,
else.
from this picture, it could be in the differential. I mean, it is
Right.
not a case of Logier-Hunziker.
Right.
Definitely.
This is one. Second is the Peutz-Jeghers syndrome. Right?
Right.
Peutz-Jeghers syndrome is another possibility. And there is still another possibility with this type of mucosal pigmentation is forgetting the name, where there is multiple, bony growth. What is that syndrome called? No, not Mafusi. Just like Peutz-Jeghers syndrome. There is multiple bony growths, exostosis of the bone, as well as pigmentation over the leaves and inside the mucosa. It's not just coming, I'll let you know.
Okay, fine. So, can it be...
Another thing.
Yeah.
In continuation with what Dr. Godse said, has the patient taken any homeopathic or Ayurvedic syrup?
No
Because
history.
those contain arsenic, many of them.
Okay.
That's why.
No history.
One.
Okay. Can it be lichen planus or lichen planus pigmentosus? Okay, fine. No. So, this is again another chocolate question. Any viral infection that can present like this, particularly the upper lip desquamation, this almost verrucous kind of appearance? Anybody from the audience also? I mean, why not oblige them with some chocolates? Sorry? 6 months. History is of 6 months. What is Heck's disease? Focal epithelial hyperplasia. No, I mean, I would need the chocolate. I mean, I have given the answer. So that is also, that should come in the differential. Anyway, no, Heck's is not. The lower lip thing almost looks like a Labian melanotic macule. But again, at this age, it is extremely unlikely. So any tests that you'd run in this particular case? Or no tests at all? Okay. Routine tests. I mean, so other than routine, nothing else. Anybody from the audience? Arsenic, petals, okay. Okay. So you would need hair and nails for that. Fine. So what we did, we took a biopsy from the upper lip because it was not matching with anything for us also. We did the TSH. Sometimes if a patient is hypothyroid, then there can be one of those areas where you can have an isolated riboflavin deficiency, right? We also did serum cortisol, though it was a long shot if it was a case of Addison's kind. There was only normocytic normochromic anemia, and on punch biopsy of the upper lip, spongiotic dermatitis with pigment incontinence, no interface dermatitis present. So, in any case, because of the vegetarianism of the patient, we thought that it might be an isolated hyporiboflavinosis, and we gave 10 mg of riboflavin tablets daily, and there was dramatic improvement within 1 month. So, I mean, this is one of the areas where you have to be, I mean, nothing. If you ask me, if I had given full B-complex, what would have altered? Nothing. But it's a, one should be aware of this possibility that let us not be carried away with this truism too much. Isolated vitamin B deficiencies do occur. Perhaps we cannot identify them most of the time. Yeah.
It's also important for further counseling of the patients.
Absolutely, absolutely. So micronutrient deficiency can present in atypical forms and may require a high index of clinical.
Isolated deficiency.
Right.
Usually some kind of a, a dietary alteration usually causes it. That's why it's very, very uncommon. A vitamin B deficiency occurring in isolation is quite. So was in this case, was there some kind of a, in this case, was there some kind of a specific pattern of diet?
Patient was vegetarian, that's it, a strict vegetarian. I mean, they were Jains and they're rather conservative kind of Jains, so I mean, that was all. And that was our hunch, that because of that, there can be hyporiboflavinosis, which proved out to be correct. Thank you. So, this is the next. This is to the other Dr. Sahana. Hemangioma on face, 4-month-old child. How will you approach this particular?
Start oral propranolol.
4-month-old child?
Yes. It's any age above 4 weeks of.
What will be the dose?
So initially, because it's in a periorbital area and it's a large.
Periocular actually.
Periocular, and it looks
so
like a segmental.
You have to treat. I mean,
You have to treat. I would also do imaging because it looks like a segmental hemangioma of the face.
Absolutely.
Like MRI to rule out any internal.
For the faces syndrome.
Faces syndrome.
Right?
And ideally.
So here is another chocolate question. I mean, if this kind of a hemangioma affecting a body segment or half of the body, half of the one side of the skin happened in the lower part of the body, is there any kind of syndrome in which there would be internal involvement or involvement of other organ systems, like faces here. Sorry?
Pelvis is one symptom.
So there will be hemangioma in pelvis syndrome? I do not think so. Yeah?
So MRI should be done in these cases.
Yeah. No.
MRI of the spine.
I am talking about any particular syndrome. This is a
Can I
chocolate
answer?
question.
Can we
It is
answer?
in the pelvic area and affecting the anorectal side, then we must go for MRI.
No, that is a separate issue. I totally agree with you. But I am looking for the syndrome. If you are looking for a
Face
chocolate.
syndrome, sir? Face.
Case is here. I
lower
want,
extremity.
yeah,
Right. So
it's
for
homologue
lower
in the lower extremity or in the lower part of the body.
Yes, there are two syndromes we have to keep in mind. One is Klippel-Trenaunay syndrome, and the other one is Parkes syndrome,
Parks-Weber.
Parkes-Weber syndrome.
Yeah, I think you can get a chocolate, but though I was thinking of another,
Lumbar syndrome.
lumbar syndrome.
Lumbar syndrome. Yes.
Yeah, she told it in the lecture. I mean, this is very specific for infantile
So
hemangioma.
pelvis syndrome has malformations.
Right,
Lumbar is
Right.
hemangioma.
right. I mean, she
Sandipan sir.
told the lecture, let's give Dr. Dhar. I mean,
No. Give it to Sahana. Dr. Sahana P. Raju.
okay. Well, so my question is basically what will be the dose? I mean,
So you admit the child, then start initially at 0.5 milligram per kg per day in 2 divided doses. And then
you start off with 0.5 mg.
Yes.
Why I ask this question is because in the US, they have this oral solution, which is unfortunately not available here.
Yes.
It is marketed in the brand name Hemangiol. And they have very strict sort of guidelines. I mean, it is 4.28 mg per ml. And they start off with 1.4 ml per kg per dose BID for at least 6 months. My question was exactly that. I mean, with the tablets, is it possible to titrate that kind of a dose?
So, the way we ask the mothers to prepare is take 10 mg of Inderol tablet and soak it in 10 ml of water, and then that you can more easily titrate it. It becomes 1 mg per ml, and then you mix it with honey or a sugar-based syrup.
Can I come over here, Somu?
Yeah, definitely.
There are 2-3 things actually. Rather, a couple of things I wanted to talk regarding this particular aspect. One is, I must first thank, Dr. Sahana P. Raju for highlighting that article in Indian Journal of Pediatric Dermatology, a review article by Professor Mancini. Professor Mancini, J. Mancini, is one of the author of very popular pediatric dermatology book all over the world, Hardwich Clinical Pediatric Dermatology. That is by Amy Peller and J. Mancini. Mancini is my very good friend actually. So he has very, rightly pointed out there also he has mentioned about the guidelines of this propranolol syrup. And he has, and this American guideline says it has to be given 9 hours apart.
Absolutely.
There is a rationale of 9 hours apart. Why not 6 hours? You cannot give 6 hourly. That means 4 times a day you will give. No, you have to give 9 hours apart. The reason is propranolol-induced hypoglycemia is something which is under-recognized.
Absolutely.
So suppose you give a child at 9 o'clock in the morning propranolol, you can watch for next few hours. And the second dose, you have to give after 9 hours. That means 9 and 18 means 6 o'clock in the evening. So that at least you have 3 to 4 hours before the child sleep to look for the hypoglycemia. So that is the rationale of, dosing schedule of 9 hours. Am I right?
Absolutely. And that was where I was going to come because Dr. Raju made a mention of 6 hourly gap.
The minimum of 6, gap
yeah,
of 6
but
hours is...
the US guideline, I mean, you can see it here, it very clearly says that not less than 9 hours gap. And there is a very good rationale for that. Okay, and may I know why would you not consider topical timolol? I mean, other than hypoglycemia, which is very well recognized, there is another very dangerous sort of side effect, that is hyperkalemia.
Absolutely.
And in fact, that can be killing. And why won't you consider topical timolol here? Because it is very apparently a very superficial kind of hemangioma.
Right.
Right?
Good point, Shomo. I must say that the topical timolol will be my first choice because I have not so far spoken about the treatment modality of it. Once I try with topical timolol for a couple of months, then probably if I don't see the response, then we'll switch over to oral propranolol. Currently, a trial is going on in our Institute of Child Health. Dr. Arijit Shah is in charge of the trial. Arijit, would you like to say something about our experience of topical timolol in hemangioma? I think so far we have recruited more than 50 patients in our study over last 3 years.
Yeah, definitely, sir. I mean, topical timolol is an excellent option, even in those cases where the lesion is around the eyes and so on.
Absolutely.
Because it can be given on outdoor basis, no need for monitoring, hardly it cause any hypoglycemia and other dreaded side effect. We have never seen any, sir.
Important thing, sorry, I am interrupting you. The main concern of using topical timolol for a hemangioma around the eyes is that because timolol is used for glaucoma.
Yeah.
But we have regularly checked, there is no reduction in the ocular pressure. That is a myth when you judiciously use topical timolol.
Absolutely.
So side-wise, profile-wise, it's extremely safe. You can give it to the baby, wait for half an hour, then instruct them how to use.
In fact,
then
it would be my first choice.
They can use at home also.
What is the dose you are giving? I mean, how many? 1 to 2 drops?
No, it's according to the body weight. Suppose 4 kg of body weight, if the baby has suppose 10 kg of body weight, so we roughly we calculate 1 drop per kg. And you divide it into 2 divided doses.
And no side effects?
No, never. Big hemangioma we have resolved with this kind of approach.
Dr. Bashir, you want to make any point?
No, sir. That's what I was trying to say. That topical timolol we were initially using before propranolol was approved. We were using it for infantile hemangiomas and it was really working very well. And I think even in bigger hemangiomas, like we have high-risk hemangiomas like on the tip of the nose, on the lips, this topical timolol works really well. Only in cases where it's not responding to topical timolol, I think we can switch to propranolol. Otherwise, we can always start with topical timolol.
Excellent.
Dr. Bashir also is working in Institute of Child Health, Department of Pediatric Dermatology over last 1 year. So what she shared is the part of this project actually.
Okay. Nice to hear that.
Thank you, Safia.
Yeah, please. Thank you. I mean, we are...
First option is timolol followed by propranolol.
Yeah.
If it doesn't work. And how many times timolol per day?
That will depend, case to case, that will vary actually. The kind of case which Dr. Sahana P. Raju shared, a case of mine, that child had extensive, hemangioma, right? Even the eyes were closed. So there was no scope of using topical timolol. Neither we expected any result with that. So there we started directly with oral propranolol.
I think the consensus could be that for superficial infantile hemangiomas, topical timolol should be the first choice. And basically,
in danger areas post-imaging, so first.
Yeah, of course. That is, of course, has to be done to... Yeah, and that's why I have fished out this article. In fact, I had published it during my editorship of IJDVL going against the judgment of the section editor concerned. And they had actually successfully used topical timolol in a case of faces.
That's what. If we have documentation that it's not involving the
Right.
vital internal structures, then we can go easily with topical.
Right, but I would not still recommend it for faces or anything. But what we did, we treated with timolol, and this is 1 year post-treatment. Once again, I repeat, this kind of picture would not be achievable if it were not a absolutely superficial kind of hemangioma. If it were deep, then of course the residual correction, cosmetic
get some
correction had to
atrophy,
be
yeah.
done by lasers. But I'm not a laser muffin anyway, and we do not have the pulse dye laser. I mean, I do not know whether Wisdom has it. So, but I'm not aware of it being anywhere in Calcutta. So, sometimes a topical therapy can be an aggressive therapeutic option, and this is exactly one of the examples. Sorry? We used a gel forming solution, 0.4 ml. Sorry?
See, he wants to know how much is the strength, 0.25 or 0.5?
0.5%.
0.5. 0.5.
I'm Dr. Ravindra from Bangalore. How long you can use this?
I mean, we used it for 1 year. As I showed here, we used
Safely?
it. Yeah. Absolutely. Now we come to case number 4. Well, this is again, I'd go to Dr. Sandipan Dhar. This is a 15-year-old boy, painful swelling left foot and ankle with fever. 1 entire month before onset of skin lesions with dysuria and sharp epigastric pain. As you can see, this is a unilateral, very asymmetric kind of vasculitic lesion. So, on close examination, these kind of lesions, one very, prominent and another resolving near the tip of the finger. These kind of lesions were scattered on multiple fingers. So what would be the differential?
I shall go first for this, with this type of presentation, multi-system involvement, anaphylactoid purpura.
Okay.
Classically, what we used to call as henoxolene purpura.
Right.
There may not be all the components of henoxolene purpura, but that's why it is better to call it as an anaphylactoid purpura.
Okay. Okay.
And second possibility will be livedoid vasculitis.
Okay.
Taking into account the necrosis part and ulceration part.
So how could you reconcile the asymmetrical appearance of the lesions?
Yes, henoxolene purpura, we have seen cases, anaphylactoid purpura. It may not be necessarily always bilateral, always symmetrical. By and large, the textbook says it is a bilateral, but many cases I have seen, and we have diagnosed finally by histology, immunofluorescence, that it is an anaphylactoid purpura, which was unilateral to onset to start with. After some time, there was a little bit involvement of the other leg. So it can be explained.
Fair
it's
enough.
not a big deal.
But, again, I'm harping on this point again and again. Can it be because of the asymmetrical nature of the lesion? Can it be a infective or septic vasculitis or an embolic vasculitis kind of?
Infective vasculitis, you have not given any features of fever, history of fever.
Fever is there.
Fever is there?
Yeah.
What is the grade of fever?
Grade of fever is around 100 to 101 degree.
For how
per
long?
night. When he presented to us, with about 3 to 4 days, he started off with the painful swelling. There was only swelling of 1 foot and ankle. And this was going on for a month. He was taking paracetamol. Fever was going off and again coming. Basically, there was no remission of fever.
Right.
So you can say that the fever went on for a month or more than a month?
More than a month. Then I would like to, so I missed the fever part.
Yep.
Then I would like to have two more, differentials in consideration.
Right.
One is COVID.
Right.
And second thing is, rickets cell disease.
Okay. Yeah. You want to have... Okay. Okay. So let me give the treatment history. A diagnosis of HSP was made by a pediatrician before the patient landed to us. He advised injection dexamethasone 40 mg per day for 4 days, to which the patient had apparently improved. It was followed by prednisone 60 mg per day, azathioprine 50 mg BD, hydroxychloroquine 400 mg per day. No further improvement, rather a progression of signs and symptoms after 2 weeks. So at this point, that is when the patient landed to us. What are the investigations that you would... Dr. Dhar, yeah? Yeah. I mean, when you can't think of anything else, you do biopsy. We do biopsy. But other than that, of course, biopsy would be needed. Biopsy with DIF, yeah. Anything else?
CBC.
Right.
Liver function test.
Okay.
Urine for RE examination.
Right.
ANA, CRP.
Right.
And fibrinogen level.
Okay. 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 So, would you consider something very rare, say Waldenstrom's macroglobulinemia among the differentials?
Yes, Waldenstrom macroglobulinemia can present like this. Can, retrospectively, if you say, right, yes, it can present like this. But that will be one of the very rare differentials, definitely.
Right.
It didn't, cross my mind, honestly speaking.
Yeah. So, basically, because the time has already ended, so we'll have to be very fast and we'll end with this particular case. We did the test, we did some tests. Histopathology is suggestive of leukocytoclastic vasculitis. To me, of course, it looked more of a medium-sized vessel vasculitis rather than small vessel vasculitis because of the size of the lesions and all. DIF shows positivity to everything. IgA, IgG, IgM, C3, everything. ANA positive. ASO, gone through the roof. The normal limit is 200 IU per ml. Here it is 978 IU per ml. ANCA negative. USG whole abdomen, there was nothing. Urine REME, nothing. Creatinine 0.8. TLC raised 15,600. Platelets, normal limit. So because of these, particularly the ASO, we went for a blood culture and it came out to be Streptococcus viridans positive. We did an echo, tricuspid valve endocarditis. So, the vasculitis secondary to subacute bacterial endocarditis. Patient reportedly recovered satisfactorily with IV injection ceftriaxone, reportedly because we had nothing to do with the treatment part of that. After the diagnosis, our role was over. So, take home message being, yeah. Be very quick because we have already passed the time.
First of all, sir, ANA without titer and pattern hardly has any importance, number one.
What kind of importance does ANA has in any way in vasculitis?
No, according to the pattern, we have to decide.
I'm not talking of pattern. In what percentage of cases ANA is positive in vasculitis?
Okay, sir. So that is the one point. That just only written down.
No. I'm just asking you, what is the percentage of cases in which ANA is positive?
Not very much, sir. Not very much.
What is the percentage?
Exact percentage I can't remember.
15%.
15%. That's what I'm 10 to 20 most probably. Yeah. Another point is that regarding, sir, vasculitis, that according to the size of the vasculitis, we have been told that there will be purpura, there will be ulcer, there will be nodule kind of according to the size of the vessel. But always it's not possible to, there will always be mix and match.
Yeah, I can understand. Yeah.
That's the point.
Thank you, Abhijit. So, this will be, so the rest two cases will unfortunately, we have to let go of that. I thank the panelists, I thank the audience for being extremely, being interactive. And with that, we close this session. Thank you. Thank you.
Thank you very much, Somo, for a very insightful, moderation with cases. Last night I could not sleep properly because of today's session. Tonight I won't be able to sleep properly thinking about your cases. Thank you very much.